Welcome to another episode of Business Talk here on businesstech.co.za. It's that time of year again, jingle bells in the stores, year-end parties, and medical aid choices. Now, let's face it, choosing a medical scheme sometimes feels like trying to pick the best route in traffic. It's confusing, there are hidden pitfalls, one wrong turn could leave you stranded with some hefty out-of-pocket expenses. But fear not, joining us today is Aron, who's a Principal Officer of Medshield Medical Scheme. With the latest benefit options for next year, Medshield aims to be more than just a safety net. They're going for a partner for life status. So, Kevin, it's great to have you with us today. As you roll out this New Year's offerings, let's dig into what's in store for members and how Medshield is tackling some of the biggest challenges in healthcare. For members evaluating their medical aid benefits this year, what are the key considerations you think that should be top of mind as they look towards 2025?
Thank you, Michael. And again, thank you for the opportunity for being on your show. It's always a great pleasure. I firstly want to say that, people shouldn't underestimate the importance of evaluating their medical scheme. A medical scheme is there primarily for catastrophe cover. Things like day-to-day benefits are very important, and they're very important to members. But at the end of the day, if you get cancer, if you need a heart transplant, if you're involved in a serious motor vehicle accident, if you need back surgery, I mean, these are very, very expensive procedures, and I mean, basically, often you're dealing with life and death. So people really need to take a lot of interest in and be active in terms of looking at what actually meets their needs. And if I can just give a few pointers, you need to look, for example, and be honest with yourself in terms of, even before one gets to affordability, what is your medical condition? What is your age? So, for example, we know that certain diseases are more prevalent at certain ages, like prostate cancer for men, typically from 50 years upwards. Cancer itself is something that, young people don't think too much about getting cancer, but as you get older, it's something that really is top of mind. And you have to look and say, what does my medical scheme offer in terms of, for example, cancer benefits? And even deeper, what options are offering what? So let me just very briefly give you an example, is that a lot of people gravitate now, because of affordability, to saying, I'm going to move down to a low-cost option. But many of the low-cost options for things like cancer will only offer PMB or PMB level of care benefits. And effectively what that means is it has to, firstly, it has to be defined as a PMB. And then secondly, in terms of the level of care, is that you'll only get what is actually prevalent in the state. So, for example, you may well find that your oncologist is wanting to actually use certain cancer drugs that are not utilized in state because of their cost. And therefore, the medical scheme has no obligation to pay for those drugs, because they'll only pay up to sort of the level that you'll get in state. And then you may have a problem. So, you have to look at these things very, very, very carefully. If you have chronic conditions, you have to look and see what medication benefits are going to be paid for my hypertension or my cholesterol. What wellness programs do they have, et cetera, et cetera. So, people really need to look into those sort of factors as well. Things, for example, like hospitals and hospital networks are also very important. Where do you live? If you need to go to a hospital, is there a hospital within a 10 or 20 kilometer radius on the network, or are you going to have to travel 50 or 60 kilometers? So there's a lot of subtleties that go into evaluating your medical aid plan that goes just beyond the financial. And I do appreciate that people are under pressure and that affordability is a major issue, but you don't want to be in a situation where you have some sort of traumatic disease. You need certain drugs or treatment, and you actually find that it's an exclusion on your option because you bought down too low.
Yeah. I mean, my brother-in-law, funnily enough, he's in his 50s. He's a professional tennis coach, had an issue with his meniscus, saw one of the top surgeons in Rosebank, and, he's a specialist, so he charges 400% of the scheme rate. And so they had a huge out-of-pocket co-payment to make. And these things can happen, judging where you are in your life. I think you can take a fairly calculated assumption on the kind of care and the level of care that you need. And ultimately, without your health, you don't have your wealth, you don't have the ability to earn an income. So these two are inextricably interlinked. Your approach has always been as a partner for life, and it sounds very ambitious. So maybe you could share more about what that positioning really means in practice and how it's shaping the kind of innovation that you're delivering at Medshield.
Absolutely. So, I mean, we design options really for your life stage, your age stage, and the ideal. And when you look at the broker market, ideally, what you want from brokers is you want brokers doing a proper needs analysis when somebody actually joins a medical scheme. And a needs analysis is not just a financial needs analysis; it's also a medical needs analysis. So that you can actually be placed onto the right option, based on, your stage of life. And what we obviously hope within Medshield is that people, as they transition, from when they actually start formal employment and they earn their first sort of paycheck, they may not be able to afford the most comprehensive option, and they probably don't need it. And I just want to say as an aside, many people are often sold options by brokers that they actually don't need. They put onto the top option, where in a sense they're overpaying because they're young and healthy, they fit, they exercise, they eat well, and in fact they wouldn't really need that top option. Maybe just a middle option would be appropriate. And then what we want, obviously, as people get older, they get sicker and they get different kinds of diseases, and they typically end up in hospital more. And for that, you have different options which have different benefits. And that's really where we talk about partner for life. And part of that, and I just want to refer to your brother-in-law, or with the meniscus and the 400%, is that one of the things that we are driving very heavily in Medshield and rolling out next year. We've already started the recruitment process, and people don't think a lot about it, and brokers don't mention it a lot, is the issue about networks, GP networks, specialist networks, and hospital networks. Now, I want to refer specifically to specialist networks. In the old days, going back 5, 6, 7 years ago, it was almost impossible to get specialists to contract onto a network. They weren't interested, but times have changed, and specialists are thinking differently, especially with COVID, because a lot of specialist practices were decimated by COVID because, there was no elective surgery. People opted not to go into hospital. And one of the benefits of a network is that you enter into a contractual arrangement with the healthcare provider, not just on rate, but also on quality of outcome, in terms of the fact that the specialist will allow you to profile them, that there's intervention, that there's engagement, there's peer-to-peer review. And one of the benefits of a specialist network is that you contract with a specialist on a set rate, and the specialist cannot charge more than that rate. So that, first of all, protects the medical scheme in terms of PMBs, because if you don't have a contract, effectively a specialist can charge any rate they want, and if it's a PMB, the scheme has to pay. But it also applies to non-PMBs, because what happens with non-PMBs is that the medical scheme is only obliged to pay at scheme tariff, but the specialist then charges 400%, and the member is then liable for the co-payment. But if you've got a contract, and what we're doing is we are rolling out specialist networks for next year across 15 specialist disciplines, and we'll contract with specialists on both PMB and non-PMB rates. So what it means is that members are protected. So if it's a PMB, the specialist will not charge more than the contracted rate. That protects the scheme. But if it's a non-PMB, he'll also charge not more than the contracted rate. The medical scheme will pay that non-PMB rate in full, and there will be therefore no co-payment to the member. So it's a win-win situation. And obviously what the specialist gets is they get guarantee of payment from the medical scheme. They don't have to go chase members for out-of-pocket expenses. And also what they do with respect is they actually get volume, because obviously the intention is that we want our network GPs to refer to specialists that are on the network. So, a lot of specialists are seeing that times are changing and that they need to be on networks. And a lot of specialists actually appreciate and acknowledge that they can't be charging 400% of scheme rate. So, just to give you one example, in the first week we've only been on a sign-up campaign for a week. And in 1 week, we've already signed up 75 specialists. And we hope that by January, we'll have about 150 specialists at least. We don't think that gives us enough coverage. So we've basically planned out that, probably around about the end of March, April, we'll have a full DSP with full coverage across 15 disciplines, and members will be completely assured that all the costs will be paid in full for both PMB and non-PMB. And those are just things that often people are not aware of and they need to think about.
Yeah. And it just shows you how schemes are changing and why it's worthwhile re-looking at your scheme, seeing what's happened, how the market has shifted, and how these kinds of innovation can give you that peace of mind. And that's really what you're doing at the end of the day. Looking ahead, I know this year there has been a lot about NHI and the big debates around NHI. Do you think that's going to spill over into 2025? Are there other specific trends or developments that you think are going to dominate the healthcare space next year?
Michael, well, look, I don't know if you're aware, but a new registrar was appointed by the Council of Medical Schemes. I think the announcement came out yesterday. I don't know too much about the individual. It's a doctor. I've heard via the grapevine that he wants to engage with the industry. But the reality of the situation is that NHI is not going to be around for a very long time. If you just look at the state of affairs of the public healthcare sector, and I think there was an article the other day that I read where even the Minister of Health acknowledged, I think Aron now acknowledged, that most of the public healthcare facilities will not actually meet the accreditation standards that will be set for NHI. So the fact of the matter is that, there needs to be a focus on fixing the public healthcare sector and less of a focus on this obsessiveness about an NHI, which actually the country can't afford and is going to take many, 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 many years to roll out. And that is reality. If I just say many people actually shouldn't be on private medical aid because they can't afford it, but they actually stay on it and put themselves under huge financial pressure because in their mind, the alternative is not an alternative. The alternative of then going into the state for them is a very scary thought. And for them, it could be death. And I say it with respect because there are some good state facilities, but on the whole, most of them need significant revamping at all levels, from the management level to the nursing level, to the equipment level, to the corruption level. And, the fact of the matter is that you don't have to be a rocket scientist to work out that NHI is not going to be around for the next couple of years. People should not be they should not be reckless and jump off a medical scheme in the expectation that next year there's going to be NHI. It's not going to happen. And government really, in my opinion, should be spending far more focus on getting the public healthcare sector up to a level that equates to the private, so that people who can't afford to be on private medical aid can actually go to the state and get the care that they want.
Yeah. And it can happen. Kevin, there are some public facilities and particular departments within those public hospitals that are um, world class. I think of certain sections of Grooteskier and also of Johannesburg Hospital, but Charlotte Manteke. But the vast majority of the public healthcare space is in dire need of just proper management. It's not even a resource issue; it's a leadership issue. And one certainly hopes that the GNU will seize on this opportunity to address that from the top down, but also from the bottom up. I think another big trend this year, and since COVID really, has been technology, and we've seen it was something of a game changer in access to telemedicine, for example. We're seeing things like AI and radiography, and there's a shortage of radiographers. So now this technology can maybe close that gap. How do you see technology in healthcare evolving over the next year or so?
So I'm not a big fan, to be honest, of virtual consultations. I think they have their place. And specifically when you look at psychologists and psychiatrists, virtual consultations are really good. I mean, you can have a counseling session with a psychologist virtually, and it works perfectly. And it's extensively used. But when you look at a lot of things, our data that we've seen is that most virtual consultations actually then result in a face-to-face consultation. And the reason really is that the technology hasn't advanced to a level where the doctor needs, very often they need to look down your throat, because you might say you've got a sore throat, but how do you know you don't have the beginnings of a tumor or a throat cancer developing? The same thing, applies when you go to a doctor. They look in your ears. Now, you can't really do that at the moment virtually. And there's a very big risk, in my opinion, that, the doctor may miss something because they're not doing an extensive face-to-face examination, and it could have dire repercussions. Basic stuff. I've got the flu. Can you write me an electronic script? That works. So, I'm at this point of the opinion that the technology still hasn't advanced to the level that it needs. But what I do believe, and I'm very, very supportive of, is what you spoke about, is advancements in artificial intelligence. Predictive models where you're taking claiming behavior and you're predicting what future claiming behavior can be. And this technology is available. There's technology that's available where it can predict for a medical scheme which patients are more likely to end up in hospital than others. And it allows you then to proactively focus on those. And, those models are accurate. So I'm very much a proponent. And for Medshield, that's really the type of thing that I'm looking at. I'm looking at AI and machine learning, to predict potential spikes in certain conditions that we can proactively then engage with our managed care partners and our healthcare providers. I'm looking at predictive models that categorize members into different risk categories, and then based on their claims and what we're seeing, predict that they may end up in hospital so that we can engage them, contact their GP proactively or specialist to try to prevent that uncontrolled admission. And then I'm very interested to make sure, and we're going to work very hard next year to develop proper functionality on apps that add value to the member. And I just want to give you an example. Especially young people who like apps, but most of the apps in the market allow you to input information, for example, for a hospital pre-authorization. But then it gets received by the managed care service provider, and they manually assess the information that's been inputted into the app, and then they will send you at some stage back a response to say whether your hospital authorization has been approved or not. Now, what I want the intelligence built in that for at least 50 to 60% of the time, if you've got the right information from your doctor, you capture it in the app and you get and you get a real-time response that says, your hospital authorization has been approved. Here's the documentation. Documentation has been sent to your specialist, and your surgery has been approved, and you can go in on Thursday afternoon. That's real value, and that takes pressure off our call centers, and it's stuff that people actually would utilize. The same thing would apply for medicine authorizations as well. Why do you need to phone a call center to get approval for chronic medication? You can do it through your app, but the app has to have the intelligence. Otherwise, people say, what's the use? And then they stop using the app. So those are the type of things that we're focusing on is building that sort of intelligence that adds value to members that say, I can see my claims, I can see my history, I can see what medication I'm on, but at the same time, if I need to engage with my medical scheme, I get real-time responses, and that adds value to me, and therefore I'll use my app. And that's the sort of technology that excites me a lot more.
Yeah, that's the bottom line. Users, if something adds value, you'll use it, you'll lean into it. But when things are developed just because everyone's got an app, but it doesn't have that functionality, that interoperability, it doesn't add value, well, then you're just doing it to chase the next shiny buzzword. Kevin, thanks so much for joining us today and shedding light on what Medshield has in store for its members next year, from tech and innovation to a commitment to being a true partner for life. It's clear that there's a lot for members to look forward to, and we look forward to catching up with you in the new year. Until then, I hope you have a fantastic festive break, because I think we're all dipping into the last bit of reserves as we sprint to the finish line of 2024. Take care.
Thanks, Michael. And luckily, Medshield's got a very high solvency, so our reserves are fantastic.
It's still very sharp at this time of the year. Kevin, Aron, to our listeners, remember, when it comes to medical aid, I think a little knowledge, as you just heard, goes a long way in making sure you're covered when it counts. Thanks for tuning in. As always, I'm Michael Avery here on Business Talk, only on businesstech.co.za.